Danias, Petros Danias. It's a pre-recorded, I think, talk. Petros Danias is director of Magnetic Resonance Center in Aegea Hospital, one of the pioneers also in CMR in our country. Dr. Danias will talk about athletes' heart and CMR in athletes.
Ladies and gentlemen, dear colleagues, good morning. It is a pleasure to be here today with you to discuss the use of cardiac magnetic resonance in athletes. I would like to take the opportunity to thank the organizing committee for the kind invitation. I have no conflicts of interest to disclose. And let's start right away by defining what an athlete is. According to the European Society of Cardiology, an athlete is an individual of young or adult age, either amateur or professional, who is engaged in regular exercise training and participates in official sports competition. The American Heart Association and other bodies similarly define a competitive athlete as an individual involved in regular and usually intense exercise in organized individual or team sports with an emphasis on competition and performance. There are various characteristics of exercise that can be used to characterize the amount of work performed and have a direct impact on the cardiovascular changes that follow exercise. And these are the frequency, intensity, time, type of exercise, and mode of exercise training, as we will be seeing in the following few slides. In this slide, we see a classification of the sports depending on the degree of exercise training as it pertains to the static and dynamic component. And one can note that various sports can be classified in different categories, and within each category there's also a difference in intensity. In both slides it is obvious that as we get to more intense sports such as triathlon, there's an increase in the intensity both in the static and dynamic component. In dynamic exercise, the heart rate gradually increases in an almost linear fashion, and this occurs in a higher slope than in the static exercise. The stroke volume in dynamic exercise increases also early on and eventually reaches a plateau value, as opposed to static exercise where the stroke volume is relatively constant. Lastly, blood pressure increases both in dynamic and static exercise, and this increase is different for different types of sports within each group. So to meet the demands of increasing exercise, the heart gradually adapts, primarily to meet increased oxygen demand, and these adaptations improve stroke volume and cardiac efficiency, and eventually enhance exercise performance and recovery. This comes to defining the athletic heart. This term is used to describe anatomic and functional changes that occur in the heart as a response to intensive exercise. And as such, we would consider at least 1 hour per day on most days of the week. So the athlete's heart is characterized by an increase of the left ventricular size. The stroke volume is either maintained or slightly increased. Left hypertrophy occurs, and this is in different degrees and different types depending on exercise. There's usually a decrease of the left ventricular ejection fraction at rest, and this is the result of increasing of the left ventricular size and maintaining the stroke volume. And lastly, the left atrial size also increases to accommodate for the increased blood flow through the cardiac cycle. Types of adaptations are different and depend on the type of exercise. In endurance athletes, where primarily we have isotonic exercise, such as in runners, cyclists, and rowers, the left and right ventricular chambers dilate, and this is called eccentric hypertrophy, and therefore the stroke volume increases. In contrast, in strength athletes, where the primary mode of exercise is isometric exercise, such as in weightlifters and wrestlers, hypertrophy ensues with thicker ventricular walls, and this is concentric hypertrophy. Also, increased contractility is quite characteristic for this group of patients. Lastly, in mixed sports, such as soccer and basketball, a combination of both patterns occurs. There are also important electrophysiologic considerations in athlete's heart, and although not a per se cardiac change, firstly, decrease of the resting cardiac frequency occurs. This is to maintain a constant cardiac output with now increased stroke volume. There's also increased vagal tone at rest, and this frequently results in sinus arrhythmia. This is very common in young athletes, and also less common in conduction delays, such as first-degree AV block or type 1 second-degree AV block. Following the left ventricular hypertrophy, there are also frequent repolarization abnormalities seen on the ECG of athletes. This slide here shows graphically the changes in an athlete's heart as opposed to a normal heart. One can note that the left ventricular and right ventricular size is larger. There's wall hypertrophy, left ventricular wall hypertrophy, and there's also an increased size of the atria as opposed to the non-athlete heart. The cardiac magnetic resonance imaging role in the athlete's heart is firstly to establish the diagnosis, and importantly to exclude pathologic conditions, cardiomyopathies such as dilated, hypertrophic, and infiltrative cardiomyopathies. In order to establish the diagnosis, one would need firstly to quantify measures of the left and right ventricular volumes and systolic function, and we all know that cardiovascular MR is the gold standard for these evaluations. The distinction from ischemic cardiomyopathy is simple and easy. Ischemic cardiomyopathy is characterized by a more regional distribution with wall thinning and wall motion abnormalities, as opposed to more global changes that are seen in the athletic heart. What is more challenging is the distinction from non-ischemic cardiomyopathy, because the two conditions can give sometimes overlapping findings. CMR can also assess valvular function and thus exclude valvular disease as a cause of the ventricular dilatation, and most importantly, it can identify myocardial scar and fibrosis and differentiate that from normal myocardium. This distinction is particularly important because incorrect diagnosis in an athlete may lead to unnecessary disqualification. On the other hand, if we miss the disease, that missed risk detection can have potentially dreadful consequences, even for the life of the athlete. CMR is the reference standard for measurement of left and right ventricular volumes, mass, and ejection fraction. And in order to measure these parameters, we use the disc area method or Simpson's rule, and this requires a regular rhythm and patient cooperation with adequate breath holding. This is rarely an issue with athletes, as they are usually young and well-trained adults. I just remind you of Simpson's rule. We take the contour of the endocardium at end diastole and then systole in various slices from the apical to the basal short axis orientation, and then the computer automatically calculates the end diastolic and systolic volume and therefore the ejection fraction. We can also measure the forward flow in the aorta using phase contrast techniques, and if we combine that with the stroke volume measurements from the Simpson's rule, we can calculate the regurgitant fraction back to the left atrium and therefore the mitral regurgitation that one can have. This way, we can have a thorough assessment of regurgitant valvular disease in the left and in the same way in the right heart. Multiparametric imaging has developed over the last several years and is an important addition to evaluating the heart. T1 mapping gives us an indication of the interstitial space, scar, fibrosis, and fat. We all know that an increase in T1 values corresponds to increased scar and interstitial tissue. We can use T1 mapping before and after contrast, and when there's knowledge of the hematocrit of the subject that we image, we can also calculate the extracellular volume. And lastly, T2 mapping is an indication of tissue edema, as the T2 values increase as the water content in the tissues also increases. After administration of gadolinium, normal heart shows a very quick intake and then wash out, as opposed to the myocardial scar, that the intake is significantly slower, but there is no early washout. So gadolinium accumulates in the myocardial scar, and we can detect it if we image late after administration of the contrast. This is because in the normal myocardium, the myocardial fibers are tightly packed. There's very little extracellular space, and as gadolinium distributes in the extracellular space in normal myocardium, there is no retention of gadolinium. In the middle panel, we see in myocardial fibrosis, there's an increase of the extracellular space, and therefore there's diffuse enhancement as gadolinium accumulates in the interstitial space. And lastly, on the right side, on the right panel, we see myocardial scar from a myocardial infarction, where there is more localized uptake and retention of the gadolinium, and therefore signal enhancement in the late imaging. There are different patterns of enhancement, and we all know about the ischemic pattern, that it occurs in a coronary distribution, starts from the subendocardium and can extend to transmural in larger myocardial infarctions. In contrast, the non-ischemic pattern is in a non-coronary distribution and is usually either subepicardial or mid-myocardial, and this is exactly what we have to differentiate between an abnormal and a normal athletic heart. Let's start talking about specific conditions. In dilated cardiomyopathy, the athlete's heart is characterized by an enlarged left ventricular cavity and also right ventricular cavity, but the systolic function is either normal or low normal, as opposed to dilated cardiomyopathy, where the left ventricular dilatation is usually followed with reduced systolic function and an ejection fraction of less than 45%. In cardiomyopathies, there's also wall thinning, and fibrosis can occur that actually also notes worse prognosis. For arrhythmogenic ventricular cardiomyopathy, The athlete's heart usually has mild right ventricular enlargement but normal or preserved systolic function, as opposed to the ARVC, where the RV dilatation is followed by wall motion abnormalities, either akinesis or dyskinesis. There can be fat infiltration or fibrosis on MRI. This may be difficult to detect, and there's also arrhythmias that can occur. The distinction between athletic heart and hypertrophic cardiomyopathy can be challenging at times. In the athlete's heart, there's usually symmetric hypertrophy, and the wall thickness is usually less than 15 millimeters. The cavity can be enlarged, and the diastolic filling is normal. In hypertrophic cardiomyopathy, in contrast, there's usually asymmetric hypertrophy. In hypertrophic obstructive cardiomyopathy, the septum is more hypertrophied than the posterior wall, and in the apical form of cardiomyopathy, of hypertrophic cardiomyopathy, there's apical thickening with preservation of the wall thickness at the basal segments of the myocardium. The left ventricular cavity is usually small, and there's diastolic dysfunction. There may or may not be late gadolinium enhancement on MRI, and late gadolinium enhancement correlates with the occurrence of ventricular arrhythmias. So in a cardiovascular MR study, their diagnostic red flags would be the wall thickness more than 15 millimeters, asymmetric hypertrophy, reduced ejection fraction and diastolic dysfunction, and fibrosis on the late gadolinium imaging. Certainly the family history can also connote worse prognosis. In athletes that stop training for at least 3 months, there can be a partial regression of hypertrophy, as opposed to abnormal pathologic hearts where there is usually no regression following termination of exercise. Athletes are young individuals, and myocarditis can occur in this age group, so it's not infrequent that these athletes will present with an acute condition such as myocarditis. In athletes, the diagnosis is exactly the same as in non-athletes. So the diagnostic CMR criteria is early T1 enhancement suggesting hyperemia and increased capillary permeability, T2 enhancement suggesting edema. These two changes can also be reflected in T1 and T2 mapping, where increased T1 values suggest increased extracellular space and increased T2 values suggest increased water content, therefore local edema. Extracellular volume calculation is also important. In inflammation, the extracellular volume increases. And lastly, late gadolinium enhancement, which can be sclerofibrosis and or increase of the extracellular space occurring in inflammation. For athletes that have myocarditis, the important issues to consider are the changes in the left ventricular and right ventricular systolic function, the extent of the inflammation, and the persistence of findings. Current recommendations are to image athletes 6 months following the acute incident in order to decide whether they can return back to their athletic workout and training. There are various challenges in imaging athletes. There are racial differences in the characteristics of the heart and the hypertrophy that may occur. Also, the use of anabolic steroids can end up in pathology, as chronic use can cause left ventricular hypertrophy, intramyocardial scarring, and increase of myocardial T1 and ECV values. In a recent study that evaluated 80 athletes that were using chronically steroids for more than 5 years, anabolic steroids for more than 5 years, almost 90% of this population had CMR abnormalities, and these mostly involve left ventricular hypertrophy, increase in the left ventricular volume, late gadolinium enhancement, and increased mass of the myocardium. So the takeaway messages: CMR can help diagnose the athletic heart and distinguish it from cardiomyopathies. We do this by evaluating the global and regional function of both left and right ventricle, and by evaluating tissue characteristics such as scar and fibrosis. By doing so, CMR can also assess prognosis. Confounders, incidental disease such as myocarditis, or anabolic use that we have always have to think about in athletes that present for imaging. In the next few minutes, I will go over a few cases that demonstrate the value of CMR in athletes. We'll first start with a 17-year-old soccer player who presented with chest pain following an upper respiratory infection. Initial troponin value was approximately 300, normal being less than 49. And this is the ECG of this athlete, showing significant left ventricular hypertrophy and deep inverted T waves in leads V3 through V6 and also in the limb leads. Now, this ECG was noted previously to be abnormal, and so this athlete had a previous workup with an echocardiogram and cardiovascular MRI. Both tests were reported as normal, and this is why this athlete was allowed to participate in sports. This is the CINE study in a 4-chamber orientation, starting from the inferior and gradually going up to the anterior wall. One can note that the systolic function is normal. The ventricular walls appear thick, particularly in the apical segment, apical portion of the left ventricle. And if we take a single frame, systolic frame at the midventricular cavity, at the midventricular level, one can note that the wall thickness at the basal segments is less than in the apical segments, and the shape of the left ventricle resembles the ace of spades, and this is quite characteristic for apical hypertrophic cardiomyopathy. So measuring the wall thickness at the base, the intraventricular septum was 1 centimeter, 8 millimeters for the 8 to 9 millimeters for the posterior wall, and in the apical segment, the wall thickness of the intraventricular septum was approximately 12 millimeters, significantly more than at the base. Late gadolinium imaging in this particular subject also shows increased signal in the apical lateral part of the ventricle, and so the diagnosis in this individual was early apical hypertrophic cardiomyopathy with coexistent myocarditis. Case number 2 is a 27-year-old female soccer player who was found to have many PVCs on a routine physical examination. 24-hour Holter monitoring showed that approximately 30%, one-third of the beats were extrasystole. Exercise testing shows PVCs at rest. Those decreased with exercise, but significantly increased at early recovery. So the patient was referred for a cardiovascular MR study after having a transthoracic echo that was really unremarkable. This is the short axis images for this athlete, starting from the apex and going to the base. Systolic function of both left and right ventricles was slightly decreased, and one can also note the increased trabeculations, particularly in the apical portion of the left ventricle seen here. In the following slide, We have a still frame in the apical short axis image showing the increased trabeculation at the apical lateral wall. Left ventricular ejection fraction and right ventricular ejection fraction were both 53% with a significantly increased left ventricular and diastolic volume. In this patient, the diagnosis would either be early non-compaction cardiomyopathy or a combination of athletic heart with RVO-TVT. You can see here how there's significant overlap with the increased size and mildly decreased ejection fraction. Both could reflect, both changes could either go along with the non-compaction cardiomyopathy or with an athletic heart. The decrease of the ejection fraction could also be a result of the significant arrhythmia load. So we suggested to treat the arrhythmia and then re-image this subject before returning to usual athletic action. The third case is a 33-year-old male professional soccer player that presented with persistent mild troponin elevation. The functional study of this subject is shown here on this slide. It shows a preserved left and right ventricular systolic function. And then late gadolinium imaging at 3 different time points, January, March, and May of the same year, shows mild enhancement at the apical lateral wall, the mid-myocardial layer, suggesting that there's a chronic persistent inflammation. So our diagnosis was that there's chronic low-grade myocardial inflammation and troponinemia, and this patient was disqualified from training. Lastly, a 56-year-old athlete who is involved with martial arts and bodybuilding, very muscular gentleman that also had routine use of anabolic steroids and occasional use of recreational illicit drugs. He presented with chest pain and increased troponin. ECG showed left ventricular hypertrophy, and this was confirmed by the echocardiogram. There was also left atrial enlargement and normal valvular function. This patient had first a coronary CT angiography, which was normal, as shown here, and cardiovascular MR study was performed after this. This is a single slice from a 4-chamber study showing normal regional function. And this is the late gadolinium enhancement of the same patient showing mid-myocardial enhancement at the basal lateral wall, suggesting a non-ischemic process. So the diagnosis was possible myocarditis. Also fibrosis from anabolic steroids or illicit drugs was considered. I would like to finish here. Thank you very much for your attention, and any questions can certainly be addressed from the rest of the panel, since unfortunately I could not be in person delivering this lecture.
Okay. Unfortunately, Petros is not with us, but anyways, he delivered a very informative, very comprehensive talk, very useful clinically. Michalis and Sophia might help for 1 or 2 comments. Sophia, I would like to make 2 comments to this very important talk. We have to differentiate athlete's heart from either a hypertrophic cardiomyopathy, generally speaking from hypertrophy, or from dilated cardiomyopathy, with sometimes borderline ejection fraction and slightly enlarged left ventricle. So correct me, Sophia and Michalis, but I think athlete's heart is associated with higher cellular component as opposed to hypertrophic cardiomyopathy or dilated cardiomyopathy, which are associated with higher extracellular component. So in those two conditions, either hypertrophic cardiomyopathy or dilated cardiomyopathy, as opposed to athlete's heart, T1 mapping and ECV are elevated. On the contrary, in the athlete's heart, T1 mapping and ECV are reduced. So they are quite accurate parameters to differentiate athlete's heart from either hypertrophic cardiomyopathy or from dilated cardiomyopathy. This is my first comment, that we have to take advantage out of T1 and ECV. And my second comment, in case of borderline ejection fraction, stress CMR might be helpful. A cutoff value more than, let's say, 10% increase in left ventricular ejection fraction from rest to peak exercise have a quite good, very good, actually, more than 90% probably sensitivity and specificity to differentiate athlete's heart from DCM. Although this threshold of 10%, more than 10% increase in the ejection fraction with exercise has not been validated. I would appreciate your comments, actually, Sophia and Michalis.
Your statement is correct. However, you know, as in medicine, everything in everything there is a however, because maybe these athletes have a myocardial dysfunction due to myocarditis, or maybe they have a form of, let's say, myocardial exhaustion, which is presented mainly with increased T2, which is not mentioned in this presentation. And now it's a hot point, just because we discuss about the T2 paradox in athletes. When they are exhausted due to very intense training, usually may present areas of increased T2 mapping. So we don't know if it is the result of inflammation or if it is the result of exhaustion. In this case, we recommend stop exercise, stop training, and after 2 months, you see the difference, that there is a normalization of T2 mapping. However, we should always keep in mind the issue of myocarditis in these patients. Just because they are young, they are exposed to different emotions, any kind of emotion, so maybe they are more prone to get myocarditis, either infective myocarditis or toxic myocarditis, or maybe they have an underlying systemic disease. I have a patient with psoriasis, and he came to me because they discovered on echo increased left ventricle. However, on CMR, no increased ventricle was identified. But it was identified an area of LGE, small area of LGE, due to past myocarditis. And when I asked the Holter saw the rhythm disturbances. So he is now waiting for a stress test in order to see what to do. Many kids with systemic diseases in early childhood are coming for training in various sports. So we have to be very careful and ask a full medical history in order to validate all potential reasons that can contribute to problems to an athlete. And definitely we need to perform serial follow-up to all these patients.
Also, Sophia and Michalis, the location of LG might differentiate DCM from athlete's heart, because we see very rarely LG in the interventricular septum in the athlete.
Yes, that's true. However, you can't exclude it. I mean,
definitely.
There are always exceptions in medicine.
Definitely.
We have to take under consideration the total clinical situation of the patient. And every detail in the past medical history and every detail in family history. If it was sudden cardiac death in the family, then they overlooked or any other problem. So a full clinical history in cardiology represents 90% of diagnosis.
That's right.
Don't forget that.
Okay, shall we, Michalis, shall we carry on with probably, yes, it's I think time for Dr. Christidi, cardiac